this particular section of occlusion number 7, we're going to be talking about several interrelated things. First of all, we'll be talking about traumatic occlusion, and specifically about the etiology and then the signs and the symptoms of traumatic occlusion. But whenever we think of that, we also have to think in terms of parafunction, which is broken down into either eccentric bruxism, that is with the mandible either off to one side or in a protrusive range of parafunctional movements. Bruxomania being the same thing during daytime when the patient is awake, or clenching either awake or asleep. Clenching, that is merely clamping the teeth together tightly, is also known as centric bruxism. And then, of course, we also have to think of other occlusal habits, such as biting on a pipe stem or habitual clamping on a pen, a pencil, bobby pins, or anything like that. And when we think of parafunction, we always have to think in terms of the effect that this has upon the teeth. You can have abnormal wear of the teeth or abnormal mobility of the teeth, or sometimes both of these things together. So again, we'll be discussing several of these various factors, and they must be interrelated at all times. First of all, now let us go to the blackboard, and we'll talk about the etiology of traumatic occlusion. If you think about traumatic occlusion, we have various factors which can cause the problem and which can predispose to the problem. First of all, under initiating factors of traumatic occlusion, we have what we have abbreviated here as central nervous system tension. That is the underlying basal activity of the central nervous system and the input to the central nervous system from other sources. A person can become, in quotes, uptight due to many, many factors in his environment, excluding the bite. Environment around him can just make him, so to speak, get uptight. Secondly, we have the initiating factors that would affect the muscles. And over here I wrote down in parenthesis Dr. Travell. You should refer to the recorded lecture by Dr. Travell on the myofascial genesis of pain. Specifically review the fact that several different systemic factors can affect the irritability or the tonus of the muscles, particularly the muscles of mastication. Very briefly, we think in terms of such things as infection about the head and the neck. We think in terms of hypothyroidism. We can think in terms of nutritional deficiencies, B vitamins, vitamin C. Too much of vitamin A and D can affect the irritability of the muscles. Muscles can also act as an allergic shock organ. If a person is allergic, sometimes the muscles go into hypertonicity as a result of that. With these things acting, then, the patient can go into bruxism. And the bruxism, muscle hypertonicity, central nervous system tension are the primary initiating factors for traumatic occlusion. Now, there are other factors which would predispose to this. This would be listed under B, and according to the book, there are specifically 12 different factors which we'll now discuss briefly and individually. Now, among the various predisposing factors to traumatic occlusion, the 12 which we briefly listed are as follows in more detail. Number 1 is a gross, recognizable morphologic malocclusion, a type of malocclusion for which the patient is sent to an orthodontist for complete orthodontic treatment to align the teeth properly. Very definitely a morphologic malocclusion is a predisposing factor to traumatic occlusion. Number 2 predisposing factor is an incoordination or a disharmony between the occlusion, the way the teeth come together, and the way the temporomandibular joints function. This is called an occlusion TM joint disharmony. Later on, we'll go to the slides and discuss this in slightly more detail. But needless to say, if the teeth do not function in harmony with the temporomandibular joint, when there is a war, so to speak, or disharmony between the teeth and the joint almost always will win out and the teeth will lose. You will have traumatic occlusion. You will have pain, signs and symptoms of traumatic occlusion in the teeth. Number 3 would be a restricted or unilateral habit of mastication for the patient. Now, there are primarily 2 reasons why a person would chew unilaterally, and these are pretty much undisputed facts which are quite important to comprehend and understand. A person will chew for convenience of function. In other words, if lots of teeth hit smoothly and evenly on one side, and on the opposite side they do not hit smoothly and evenly, the patient will end up with a convenience of function. He will masticate, therefore, on only one side because that is more convenient. And number 2, a person will, again, subconsciously will avoid pain during mastication. If you have a loose filling or a cavity on one side of the mouth, the patient will avoid pain in that area and will chew on the opposite side. So again, the third predisposing factor to traumatic occlusion is a restricted or a unilateral type of mastication. A person will chew unilaterally for convenience of function and to avoid pain in the masticatory system. The fourth predisposing factor to traumatic occlusion is a loss of teeth, particularly posterior teeth. Many, many years ago, a classic article in the dental literature by one of the early, very famous dentists described 33 pathologic changes which could occur in a masticatory system following the extraction of a mandibular permanent first molar. This would include the mesial and lingual drifting of the mandibular second and third molars, and obviously with this concomitantly the extrusion of the maxillary first molar, loss of continuity of the contact points with resultant food impaction, caries in these areas, followed by periodontal disease, deepening of the pockets, loosening of the teeth, and with the drifting of the teeth, an introduction of citric relation prematurities as well as balance and working side prematurities. One of the primary problems that you will face in your clinical practice is many of your patients will dread the thought of losing an anterior tooth where it shows, and they'll be happy to have restorative work done. On the other hand, many of the lay public will feel that the loss of a posterior tooth which does not show is of little or no concern. However, the long-term longevity and health of the masticatory system is probably more in jeopardy with the loss and non-replacement of a posterior tooth than the loss and non-replacement of an anterior tooth. I would refer you to the textbook to read up further detail on the consequences of loss of a posterior tooth. The fifth predisposing factor is periodontal disease. The more severe the periodontal disease, the more severe the amount of alveolar bone loss around the teeth, the more the teeth tend to become mobile and therefore become more of a predisposing factor to a bad bite or to a traumatic bite. Number 6, dental caries can lead to traumatic occlusion. Proximal caries, which is not properly and adequately restored early, can cause unusual mesial drifting and tilting of teeth, which in turn could give you centric prematurities as well as balance and working side prematurities. Number 7, faulty dental restorations are one of the primary causes of traumatic occlusion, and later in the module on Occlusion VIII, we have one section entitled Occlusion in Restorative Dentistry, and it's quite important that you understand that in everyday restorative dentistry that you can either prevent traumatic occlusion help to instigate traumatic occlusion by everyday restorative dentistry. Number 8, faulty orthodontics, improperly done, can also lead to traumatic occlusion. As well as number 9, faulty occlusal adjustment, a faulty technique for grinding the teeth, rather than eliminating traumatic occlusion, can introduce additional traumatic occlusion. As I have in parenthesis here, the primary way of doing this by a poor or faulty technique is a technique in which the dentist would grind on the cusp tips and or grind on the incisal edges of the anterior teeth. By doing this, grinding on cusp tips and on the incisal edges, one has a tendency of eliminating the stabilizing centric forces of the centric holds in the central fossa region. Thus, rather than creating stability, the dentist, by grinding according to these techniques, will tend to create instability of the dentition, which in turn can then lead to traumatic occlusion. The 10th predisposing factor to traumatic occlusion would be occlusal habits. This is excluding bruxing, bruxomania, and clenching. Occlusal habits would be such things previously slightly alluded to. Habits such as clenching on a pipe stem, pencil, pen, using bobby pins to open teeth, etc. These type of occlusal habits will tend to push a tooth out of proper and normal alignment, create excessive forces on these teeth. It can help to create the buckling of the arch, settling and drifting of teeth, and creating traumatic type situations which would not exist had this type of habit not been there. The 11th type of predisposing factor would be jaw fractures, either a traumatic type of a fracture or a neat, clean oral surgical procedure for a prognathic reduction, oral surgical procedures to reposition premaxillas, and the various types of operations like this. In any case, whether it be a traumatic fracture or a neat, clean surgical type of procedure, once these jaws are repositioned, wired, and then healed, it is quite possible, in fact usually always following this type of procedure, you have interferences in the functional occlusion built into it which did not exist prior to the oral surgical procedure. Number 12, and the final predisposing factor to traumatic occlusion, is inadequate tooth form and position of the teeth. In other words, you may have very healthy and normal-sized crowns of the teeth, but for one reason or another inadequate or poorly shaped roots which cannot tolerate forces on the teeth, create instability of the tooth, and in this way leads to a drifting and shifting of the teeth and therefore a causing of traumatic occlusion. Now the next thing that we'll do is to briefly describe and talk about the signs and symptoms of traumatic occlusion. Traumatic occlusion are dealt with extensively in the assigned reading in the textbook. This is meant to merely briefly outline them. One of the first signs of traumatic occlusion, and probably one of the most important signs, is an increase in tooth mobility, particularly if you do a careful periodontal probing of the teeth and find that there is little or no periodontal pathology present, no pocketing, and according to the radiographs, little or no resorption of alveolar bone. And if the teeth are excessively mobile, this is a strong indictment of the fact that you do have a patient with traumatic occlusion. The second sign in traumatic occlusion is a change in the sound of percussion to the teeth. Normally with healthy teeth, when you would percuss the tooth with a dental instrument such as the back of a metal mirror, you will have a rather sharp ring or sound, and this will not be sensitive or tender at all for the patient. When you have a tooth that has been in traumatic occlusion, due to the changes which occur in the periodontal ligament, you will experience and hear a rather dull sound, a rather like a thud rather than a sharp resonant ring to a healthy tooth, one that is not in traumatic occlusion. This is a definite sign of the changes which are undergoing inside the periodontal ligament itself. The number 3 sign would be migration of teeth. Now, migration of anterior teeth, particularly my anterior maxillary teeth, extrusion, opening up a diastema, is the number 1 clinical sign of advancing periodontal disease. It's also a sign of traumatic occlusion, and quite often you'll see periodontal disease and traumatic occlusion of anterior teeth going hand in hand. Number 4 is atypical wear, and we will show several cases of this in a few moments. You need to be aware at all times of the status of the occlusal or incisal surfaces of teeth, and look at all times for signs of atypical wear to one or a few segments of teeth. Number 5, hypertonicity of the muscles of mastication. We will discuss this a little bit more thoroughly with slides in just a few moments. And number 6, another classic sign of traumatic occlusion is periodontal abscesses. Now, particularly the type of periodontal condition which can be aggravated by traumatic occlusion are your infrabony pockets, your 2- and 3-wall infrabony pockets, and bifurcation and trifurcation involvements. It is fairly well established now that the force or the pressure from traumatic occlusion can literally force the bacteria into the periodontal tissues, out of the periodontal space, and in this way then we get an abscess formation. So whenever you see a patient presenting with a periodontal abscess, you should automatically think in terms of traumatic occlusion in that particular patient. Now, the next thing in the list of traumatic occlusion would be the symptoms of traumatic occlusion. These are quite often things that the patient will come into your office and complain about. Number 1, he might complain about periodontal pain. He might have teeth which are sore to bite on, or again, if you percuss them, they will be sore to percussion, and yet there won't be any periapical involvement or caries involvement. But it could be a soreness, an inflammation in the periodontal ligament due to trauma from occlusion. Another excellent symptom of trauma from occlusion is pulpal pain, particularly to cold. If you put in a new restoration, and if that restoration is high, the patient will come back and complain within a couple days or a week that shortly after you put in the restoration that the tooth became exquisitely sensitive to cold. This is due to a hyperemia, a slowing down or a cutting off of circulation to the pulp due to trauma from occlusion, depressing the tooth in its socket. Number 3, quite often we can have referred pain. It can be referred pain either from the pulp or from the periodontium or from sore muscles of mastication. A 4th symptom quite often seen is food impaction, and the number 1 problem here would be a plunger cusp, which would be ramming food between 2 of the opposing teeth, collecting the food proximally and down below the gingival margin and eventually causing periodontal problems. The number 5 symptom would be temporomandibular joint pain dysfunction syndrome, or TM joint arthritis type of problems, and or concomitant with that myofascial pain, pain of the masticatory muscles, and associated with that would be referred pain to distant sites. Again, I refer you to Dr. Travell's lectures in this instance. Along with this, in point number 6, we can have loose teeth, and the patient complaining of an itching feeling either in the teeth themselves, and the patient will tell you that it feels good to rub the teeth together to help to get rid of some of the itchiness. Sometimes the periodontium itself, the gingiva, has a feeling of being itchy, and the patient will dig around, usually to his detriment, with a toothpick, and will cause problems in in this way. So these then are a summary of the signs and the symptoms of traumatic occlusion. And I think now we might go to the slides and go through some things before we come back here to radiographic signs of traumatic occlusion. Again, just to refresh your memory, where we are, we're talking about dysfunction or pathology of the masticatory system. And we're talking, in this case, about problems which occur with the teeth themselves, signs and symptoms of traumatic occlusion. And again, this slide, which we showed in a previous segment of this tape, discusses the delicate interplay between muscle function and the occlusal program, and how muscles, when they go into spasm, can cause traumatic occlusion. On the other hand, traumatic occlusion by itself can cause muscles to go into spasm and can create an even worse problem. So clinically, the problem that you will have is to figure out which came first. We were talking earlier about the influence of the various factors of occlusion upon creating traumatic occlusion. In this case, the curve of Spee and the plane of occlusion. And we mentioned this in one of the earlier modules on occlusion, the Thielemann articulation formula, and the way in which the teeth would come together, and all of these various factors, the condylar inclination, the incisal guidance, the curve of Spee, the plane of occlusion, and the cusp height. They're all delicately and intricately interwound one with the other. To change one of these factors will definitely affect other factors. And if you change one or two of these factors and don't understand and take into consideration how this will affect the balance of the factors of occlusion, this then can cause or lead to traumatic occlusion. What are the factors in occlusion itself? Well, if we go back to this slide, the kinds and the numbers of occlusal factors in dentitions with a full complement of teeth will come to a total of 138 different factors. And if you remember from the earlier module, we talked about the various inclined planes of the teeth which come into play and are quite important. The propulsive facets, or that is the areas of the teeth which help to guide the mandible into protrusion, the retropulsive or the retrusive facets which come into play between centric relation and centric occlusion, and then the balancing type of facets. Practically every incline of a tooth will have some part to play in determining how the maxilla and the mandible will function one against the other. Now, this is a photograph which was taken out of our textbook on occlusion from chapter 11. We talked about the signs and symptoms of traumatic occlusion and how muscle hypertrophy can be one of the signs of traumatic occlusion. In this particular case, you see a young girl with a bulging masseter muscle on one side as a result of chronic bruxing. This muscle was in hypertrophy. This muscle was rather normal. Following occlusal adjustment and therefore a cessation of the bruxing, this muscle eventually reduced in size until she had pretty much facial symmetry once more. And you see down here in this case the bulging masseter muscles, which in some social circles is the sign of healthy, virile, handsome young fellow. Unfortunately, these type of muscles usually are quite indicative of bruxing, and while in some cultures it may look very handsome, if you look at the dentition, usually that particular patient is in trouble. All right, now we talk about some of the signs and the symptoms of traumatic occlusion. You see this case here. We used this illustration earlier to demonstrate a centric relation slide from RC to IC, where the mandible came forwards and closed vertically and moved to the patient's right side or to the left of the screen. We have a pathologically occurring diastema in this case, and if you look up here, due to bruxing, we have abnormal wear of the maxillary right lateral incisor, so that now this tooth is shaped more like a spear or an arrow than it should be if you compare it with the opposite side. This patient also had periodontal disease, tooth mobility, and some temporomandibular joint problems, all rather characteristic and classic of traumatic occlusion. Now, we discussed the fact that you can have atypical, uneven, and abnormal wear of the teeth. Quite often, when a dental student or a dentist is observing teeth, he'll never look at the teeth together like this, or with the teeth just barely separated. If you look here, you can barely see a hint of any sort of problem. However, if you ask the patient to separate the teeth slightly, you will notice that there's quite an uneven incisal edge for these teeth. You can see right about here is where this changes, and the same thing occurs in the opposing arch. Excessive wear on the anterior teeth indicative of bruxism, because this wear pattern is outside the usual normal functional range. This particular case is even more dramatic and a little bit easier to detect. Ask the patient to separate the teeth. It looks like somebody had come in with a high-speed stone and tried to grind in a bad bite. Yet the patient by herself has done this through the years with subconscious grinding of the teeth during sleep. This is an interesting case here that presented at the dental school several years ago now. It looks almost as though these teeth were chipped accidentally. However, such was not the case. The patient was a chronic compulsive bruxer and did this to himself down through the years. As you notice back here, you see a gold crown in place and you see an aluminum crown in place. There are several morals to the story here for a clinical dentist. The young dentist taking care of this patient did not recognize this anterior wear before he began treatment, did not realize that this patient was a chronic bruxer. Luckily, he did not start by trying to replace and restore the anterior teeth, or else he would have been in big trouble. Instead, he started in the posterior, and you see one aluminum crown and one gold crown, the reason for this being that the patient would brux every night and would knock the aluminum temporary crowns off and either spit them out or swallow them. The patient, therefore, the dentist, therefore, in a hurry to get the patient comfortable, temporarily cemented the two gold crowns in place. The patient, the very first night that the bicuspid permanent crown was temporarily cemented, bruxed it loose and swallowed it, and at the time of this photograph, the gold crown was halfway from the esophagus to the other end of the tube, and the patient was patiently waiting for it so that he could sterilize it and then re-cement it. The problem that a young unsuspecting dentist will get into is that if you can get the restorations to stay in place, it is somewhat of a miracle while the patient is undergoing active bruxing, the results of which you see here. Even more dramatic and something to stay away from is a restoration of the anterior teeth if the patient is still bruxing. For whether it be porcelain fused to gold or any other type of material, the patient will continue to brux, and either through the gold or the porcelain or whatever, will continue to brux and will wear down the restorations, as well as possibly, if there is porcelain involved, will wear down the anterior natural teeth at an even faster rate. This is a young adult, about 18 years of age, with chronic bruxing, and you see here the excessive amount of wear on these permanent teeth. Closer up view of the problem here. This is another patient with, again, excessive wear on the teeth. In this case, it is practically all of the teeth in the dentition, say perhaps excluding some of the posterior teeth. The view of the mandibular teeth, you see this yellowish area here. What this is the underlying dentin with the entire enamel overlying this being completely worn away through chronic bruxing. The same patient with the teeth slightly separated, to give you an idea of how these people can really wear out their teeth. Sometimes you will see just a few teeth which have extremely abnormal wear. This is probably one of the most classic cases that I've seen in recent years. This extreme cupping out of this tooth, the mandibular canine, and a couple of the anterior teeth. The patient gave no history at all of trauma, such as a car accident or a football accident, to these teeth, and had no recollection whatsoever of grinding on his teeth. Yet, whenever you see something like this in the dentition, you should immediately be alerted to the fact that something is going on in that mouth and that could create trouble for you as the restorative dentist later on. A slightly different view of the same problem. So far we've been showing you abnormal tooth wear on the anterior teeth. This happened to be a young sailor who was a dental technician of mine many, many years ago now. With the teeth slightly separated, he had reasonably little attrition on the anterior teeth. But if you start to take a look at the posterior teeth, you'll see something rather interesting. As you go back from the cuspid to the first premolar, the second premolar, first and second molars, you'll see an increasing amount of wear on the occlusal surfaces of these teeth as you progress more posteriorly. A different view of the lower here shows you the cupping out of the amalgam restoration around these teeth. This presents quite a restorative problem for the restorative dentist because as the bruxing continues, the enamel is worn away to the point that the restorative dentist has little or no enamel edge to finish his restoration to. And then one is forced into the situation of should you not restore the tooth, or if you're going to restore the tooth, you must have an enamel edge to finish to. So therefore, you must think in terms of a minimum of a gold onlay restoration, or perhaps even a crown. This is another rather interesting and classic case of a abnormal wear, in this case strictly limited to the maxillary and mandibular cuspid teeth, your canine teeth. And you see the way these things are rubbed or worn in together. We happen to call these areas here the bruxofacets. These are wear facets put in the tooth through bruxing or abnormal parafunctional usage. Whenever you're examining a dentition, you should look for bruxofacets for the evidence of abnormal wear on the teeth, be it either two single teeth like so, the anterior segment, or the posterior segment as described in the previous case, or the entire dentition. This is a poor photograph due to Dr. Adams' bad intraoral photography. This happens to be a cord in the way. But if you will look around that and pay attention to the dentition, this is a lady in her 50s, perfectly healthy dentition, but she has excessive and abnormal wear of all of the teeth, upper and lower. This shows how most of the teeth were fairly well flattened in the maxilla, and how you see the same thing in the mandible. The yellowish area you see here is all dentin. The only thing left near the occlusal surfaces of these teeth is a ring of enamel around the outside. Excessive amount of tooth wear due to compulsive bruxing. The treatment in this case is to cover both upper and lower arches with full coverage horseshoe-shaped occlusal splints, which the patient wears at night, as you see here, to prevent further wear to the teeth themselves. The indications, contraindications, fabrication, design, etc. of bite plates and occlusal splints will be gone into in greater detail in the following module, Occlusion number 8. We now should spend a little bit of time discussing the radiographic signs and symptoms of traumatic occlusion. Signs and symptoms of traumatic occlusion are sometimes very dramatic, but on the other hand, sometimes a little difficult for the uneducated eye to recognize. So first of all, we'll discuss them on the board and then go back to the slides and see if we can illustrate some of the points. First of all, you might find an altered lamina dura in a periapical radiograph. The alteration of the lamina dura can be as minor a thing as just an uneven lamina dura with somewhat of a moth-eaten appearance, all the way up to a thoroughly and completely missing lamina dura. Usually with a tooth under excessive traumatic occlusion, there's no lamina dura present. Quite often under rapid orthodontic movement on an x-ray, you won't see a lamina dura. So it can be anywhere from a slight moth-eaten appearance to completely missing. Number 2, you'll usually note an alteration in the periodontal space, the little space between the root of the tooth and the lamina dura. A tooth in normal function has a rather characteristic width to it, and this is gone into in greater detail in the textbook on this particular subject. A tooth which is in excessive function or in traumatic occlusion will, generally speaking, have a widened periodontal space, particularly in the occlusal aspect, occlusal to the fulcrum point on the tooth. And this has also been referred to as the funneling appearance of the widening of the periodontal space. Number 3, with excessive traumatic occlusion, you will note on x-rays root resorption. Again, this is sometimes seen in post-orthodontic cases. Number 4, as a result of chronic, long-standing traumatic occlusion, we can have hypercementosis of the teeth as well as an osteosclerosis of the surrounding bone. Number 6, sometimes the trauma from occlusion is severe enough that we will note root fractures of the teeth themselves. And sometimes we'll note pulpal calcification as a result of trauma from occlusion. Well, so much for a brief outline of what we see radiographically. Let's now go to the slides and go through these and see if we can point out some of these factors for you. The first slide we have here shows the results of having a bicuspid with a high crown, as you can see in this area here. This is the high crown and the offending tooth. If you look over here on the periapical shot, you should be able to see that we have a thinning of the periodontal membrane space. We have hypercementosis in here, and as well we have a thickening of the bone itself, or you might say an osteosclerosis of the area surrounding this. You see the same thing on this tooth here. Now the next slide shows us shows periapical films of a patient with heavy function. We do have some root resorption and some osteosclerosis in the area right here. This is a patient that was bruxing and creating excessively heavy forces. There's no particular evidence of periodontal disease in this case, but you can see a thin but rather well-defined periodontal ligament around these teeth. The next slide shows occlusal trauma due to tooth loss, obviously the mandibular teeth being extracted in this area, extrusion of the upper teeth and drifting forwards of the lower teeth. As a result of this, we have some slight widening of the periodontal ligament space in here and in here. This next case illustrates trauma from a high inlay, trauma to a lower bicuspid due to this well-fitting restoration up in here. And again, we can see extrusion in this area. You can see rather well here, I believe, the widening or the funneling effect of trauma from occlusion on the periodontal membrane space. This next slide illustrates a fixed bridge, a permanent FMR type of restoration. This restoration was high. The entire bridge was high. And you have occlusal trauma from the fixed bridge. You have the trauma not only on these teeth here with a widening of the periodontal membrane space. You see in this particular case here, it is rather difficult to pick out a very definitive lamina dura, although we do have a lamina dura on these posterior teeth. The next slide is rather dramatic and shows the effects of occlusal trauma from a removable partial denture. You can see quite well in this case here an excessive crescent-shaped bone loss around the abutment tooth. Down below you see signs of hypercementosis due to trauma. Unfortunately, the poor abutment tooth, while it has some slight signs of hypercementosis, has an accelerated amount of bone loss. The next slide we see excessive alveolar bone loss in the anterior teeth and on the bicuspid, the first premolar cuspid area. This particular patient, as you can see here from the radiographic appearance of the incisal edges and of the cuspid here and the moon-shaped crescent ditching out of the cuspid here, should be indicative to you by this time of a patient with rather severe compulsive bruxism. The compulsive bruxism in turn not only wore the teeth in an unusual manner, but helped to accelerate and accentuate the alveolar bone resorption around those teeth. The next slide shows periapical evidence of trauma from occlusion. As you see in this particular tooth here, there is a small restoration in the tooth. There is no caries. The same thing in this tooth here. Some slight alveolar bone loss, some periodontal disease, but because these teeth are in excessive trauma, you can see up here the results, which are quite evident radiographically, of a thickening of the periodontal membrane space in the periapical area. This particular slide shows quite obviously what happens when you extract the tooth and don't replace it. You have an extrusion of the upper molar so that your contact relationship is like this. As you look down here, you can see rather severe alveolar bone loss on the distal one-half of this molar. You also have rather severe bone loss in the mesial aspect of this. If you now come over and look at the bite wing x-ray for a moment, and remember back to function of the mandible, when the patient swallows, the mandible attempts to retrude to centric relation, and then posterior teeth will contact each other, usually the mesial inclined planes of upper teeth against the distal inclined planes of lower teeth. And this is exactly what's been going on here and traumatizing these areas through the years with selected tooth removal and not replacing those missing teeth. We talked about how occlusal habits can be predisposing factors to trauma from occlusion. This radiographic evidence here and here of rather selective, localized, severe alveolar bone loss in this area and in this area here. The reason for this being a chronic habit, long-standing habit of opening bobby pins with the upper and the lower anterior teeth. You see it here. You see this particular tooth is niched, and this one over here. The anterior teeth for this lady have suffered rather tremendously from a pernicious habit which should be intercepted and stopped as soon as possible. The next slide illustrates occlusal trauma, which is related to an inlay, in this particular case a DO inlay and a maxillary left second premolar. This particular restoration was high in practically all excursions. You can see we have some selective palatal bone loss in this case, a widening of the periodontal membrane space, widening at the apex. The tooth has been forced distal. We have an opening of the contact area here. The trauma to the lower tooth also shows the funneling or the opening of the space down here. Now, the next thing that we see is a distal drift of a mandibular premolar caused by occlusal forces and also compounded by the extraction of a mandibular second premolar, which was not replaced in this case. You can see in the bite wing x-ray that as the patient closes together, the inclined planes of the maxillary teeth contact the lower tooth in such a manner as to drive it distally. Very well. This then is a summary of the etiology and of the signs and symptoms of traumatic occlusion. In the next segment that we'll go into, we'll deal with temporomandibular joint dysfunction syndromes and with myofascial pain.